founder and clinical director of Golden Vision with 10 locations in California. He is the fellow of the American Academy of Orthokeratology and Myopia Control. And this fellowship was only rewarded to less than 150 doctors worldwide. Dr. Dennis Leung is the expert in the field of Ortho-K for more than 20 years, which also make him the FDA investigator on Ortho-K lens design. Dr. Leung is also the adjunct professor at the Western University, where he has lectured his doctoral colleagues on the subject of fighting the worldwide epidemic of myopia. Many of his students are doing Ortho-K and myopia control throughout the US and the other parts of the world due to his teaching. And now, exactly what is myopia? How does it affect to our eyes? And how can we prevent and control myopia? So now I'm going to pass the time to Dr. Leung to tell us all about myopia. So hi, Dr. Leung.
Hello. Hi.
Hi.
I hope everybody is, being safe at home and safe and healthy. And today, I'm going to be talking about myopia, its cause, its effect, and how to prevent myopia. So let's talk about what myopia is. And today we have a few objectives. We want you to understand what myopia is versus hyperopia, which is opposite to myopia. And we want to talk about what is a normal growth of the eye and what is not an abnormal growth of the eye. And we want to know about, we will learn about the prevalence and how prevalent is myopia worldwide and the reason for myopia to develop or nearsightedness to develop. And we will talk about what are some of the eye disease associated with myopia or nearsightedness and what we can do to prevent it. So those are some of them, a few things I want to, sort of share with you. So first, the myopia is nearsighted, so we cannot see things far away, but you see things very close. So if you're myopic, you're nearsighted, meaning that you cannot see things 20 feet away, like watching a movie in the theater, or when you're driving, you need a pair of glasses. When you read, you generally don't need a pair of glasses to read. So here you have a picture and then sort of like a cross section of the eye. The top picture is a normal eye, and the normal eye, the light will come in when you see something far away. The light come in will focus right at the retina. You see the red dot is right on the retina. For myopic eye, which is farsighted, the eye is farsighted. The eye is nearsighted, sorry. And the eyeball is too long, so the light is focused in front of your retina, so causing a blurry vision when you see things far away. So the next slide here is the condition called hyperopia. Hyperopia is eye too short, meaning the image, when you see things far away, the image will be landing behind the retina, but the way our function of the eye, they have a lens, a muscle in the eye, so you can move the image onto the retina, right onto the retina, and even though eye is too short, meaning the people who has hyperopia generally don't need glasses when they're young, because when they're young, the eye are very flexible and they will be able to focus up close. So even you're hyperopic, you don't need to worry about it unless you're very highly hyperopic. You're highly farsighted, you probably don't need glasses when you're young. So the next, from this slide, you can tell that the eye, the top image is a hyperopic eye. So the image is focused to the back of the eye, but because it's focused to the back of the eye, as one grow, let's say when they're born, when a child is born, the eyes is too short. So as one grow older, the eyeball will grow longer and longer, catching up with the image to the back of the eye, and hopefully by the time they become adult, and the eye will be in perfect length. This is a process called emmetropization, which is a normal eye growth. The other is a pathological growth of the eye growing too long, which is very common in Asia. So the eye is growing too fast. So when you're born, the eyeball is too short, but then it overgrows to a normal stage. So during teenager, the eye become too long and it become nearsighted. So here is a chart so we can understand the concept a little bit. When the baby is born, and probably they will be some range of hyperopia. So in this example, the baby is born is 3 diopter too short, the eye. So you can see well, it's normal. By 4-year-old, the eye become longer, it become hyperopic by 2 diopter. By 8-year-old, as the eye grow longer, the hyperopia become 150, but you can still see clear because the eye has this focusing ability to focus over the 150 diopter of hyperopia. But as it grows longer and longer, by the time they become adult and 20 years old, the eye is in perfect length. So no prescription at all. That would be the ideal growth. So next slide, we'll have a non-ideal growth. The non-ideal growth is very common among Asian, is the eye are growing too fast, go long too fast. So a baby of 3 diopter of hyperopia, by 4-year-old, it become 1 diopter. By 8-year-old, the eyes are normal. It's in perfect shape. But then eye continue to grow tall, the longer as the kid grow taller, then by 12-year-old become -1 diopter of myopia, and by 16, -3, by 20-year-old could be a -6. This is just an example to illustrate, abnormal growth. The eye grow faster than it should be, and that causes so much, the eye being nearsighted. In Hong Kong, you can do a survey have shown that by 6-year-old, about 20% of the population in Hong Kong, mostly Asian in Hong Kong, mostly Chinese, about 20% of that age is already myopic. So the eye grow really fast. By 6-year-old, it's already longer than it should be. And by 12 years old, about 61% of the population is already myopic. So that's very alarming. So more than 50% of the population by 12 years old, the patient is already myopic. So this slide shows our world, it's also geographically located, meaning the epidemic of myopia sort of changes from place to place. In the US, about 50% of our populations are myopic. And if you jump over to Asia, Hong Kong, Singapore, and Japan is a much higher rate. Japan of 60%, and South Korea, 97% of the population are myopic. So it really varies among location, but you can see in the Asian area, near Asia, the myopia, the prevalence of myopia is much, much higher. So the prevalence of myopia have 2 factors, and why it is, from the geographic region, we figure, well, maybe it has something to do with genetics. Correct. It's roughly 78%, probably 80% of our population, of the the reason, the contributing factor to myopia is genetics. So it passed from one generation to the other. So if you have one parent being myopic, you have a 1.5 chance more risk to develop myopia than you will have no parents being myopic. But if you have two parents, both parents are myopic, you have a 3 times more risk. And also, if the myopia of your parents are high, like let's say a -10, -8, -9 diopter myopia, your chance being myopia is naturally higher because genetic, factor is about 78% of the reason you get myopia. But the 20%, you see, it has to do with environment. So the environment has a lot of influence also about how fast your eyeball will grow in length. Basically, myopia is an abnormal lengthening of the eye. So I'm going to direct this question to our panelists, Dr. Tsang from San Francisco, and you can share about your knowledge on the environmental influence of myopia progression.
Thank you, Dr. Leung. Yeah, so we did a talk about 2 weeks ago, talking about, with our kids being at home more, work from home more, what does the environment have to do and how does that affect prescription changing, not just how comfortable are your eyes, but for kids who are still developing. How big is that risk? Is it completely overhyped or is there a true kind of scientific medical backing to that? So we definitely have gone over the 20-20-20 rule. There's a lot of studies that show that with reading and computer near work, that distance that you are from your reading object is a big factor in nearsighted growth. And so we do want to reiterate with our kids and kind of grind into them the habits of taking breaks. So the 20-20 rule, I'll repeat again from last time, is every 20 minutes, take a 20-30 second break, looking away about 20 feet. So if you're inside a room without a window, maybe walk out, look down a hallway. If you're able to look out a window, great. But, those all sound kind of silly to kids sometimes, but they do definitely make a big difference. And so the environmental factor, even though maybe not quite as much as the genetic factor, it does definitely, this is the part we can control. And so we really want to do that. So taking breaks at near work, getting outdoors. So there's some very interesting studies. What we do here is we want to do medical-based, evidence-based medicine. So there's some very interesting studies where they looked at Eskimos, which, are very isolated. They, do fishing, they do all of that. As soon as these Eskimo tribes became urbanized and started going to school and getting more educated, there was a high influx of myopia in the population. So there's many, many studies like that for kind of more tribal isolated groups. And there's also a lot of high correlation with being kind of more urban areas in general, because if you're in a city versus in a very rural area, you are in a smaller space, you maybe don't have as much break, you're maybe not as outdoors as much. So people living in an urban environment do tend to have higher education, different type of environment setting, and maybe lifestyle-wise not as conducive to maintaining the ideal growth that Dr. Leung was talking about. And then there's also a portion that is nutrition. This is still kind of out in the books, but making sure we have well-balanced diet on top of taking breaks on the eyes is very important. So with nearsightedness, kind of our take-home is it's partially genetic, partially environmental. And what can we do about the environmental part where you can actually control? So we're going to take a little bit of a break right here. And just kind of, we've got a few people here with us today. We wanted to know how many of you yourself are myopic. So we don't really know, it's kind of more fun, more interactive when we kind of know our audience when it's live. So it's really cool that we do this. But just take a second, are you all myopic? Is there anybody who's not? It kind of gives us a good picture of who we're talking to. Wow, very good. Okay, so we're so far at about 12 out of 17 of us, so about 70%. A few of us voted. Okay, so quite a lot of us here, Dr. Leung. So when you're kind of talking about that, it's nice to keep in mind. So we've got pretty much a huge majority of you, if you can see that, is myopic. And then I also want to kind of ask, of those of you who are myopic, how many of you are higher than a -5? Now, sometimes we don't know our prescription, but if you do, I'm just kind of curious. 0 would be no prescription for those of you who, you know, are. And then -1, -2. Give it a few more seconds. Very good. We've got a few of you here. So this is, we've got about 17% is kind of what we would categorize typically as high myopia, and about 83% that aren't. So why is that important? I'm going to throw it back here to Dr. Leung, and he's going to go into a little bit of why we want to prevent prescriptions from getting too high.
That's a really good survey, and I bet among the audience here, there's probably a lot of Asian, and why, you know, I think not only that we have a very high prevalence of myopia, and also we have a pretty high percentage of high myopia. Why I said high myopia, why do I put the survey, I purposely put down a 5 diopter as high myopia or high nearsightedness, because higher than -5 statistically has shown a tremendous increase in the risk of developing eye diseases, sight-threatening eye diseases. And for retinal detachment, which is a detached retina, a retina actually detach out, people with a higher than -5 diopter or myopia, you know, you have a 21.5 times more risk of having the retina sort of tear during your lifetime to sort of peel off the back of your eyes, and you could lose a lot. You can permanently lose your vision, a lot of your vision, even after repair. So other disease that is related to eye myopias are, and can go on the next slide here, is very common, which is vitreous floaters, meaning you see a little, like almost a mosquito or hair-like floating across your eyes, very common among myopic patients. And if you have a high myopia, for development of these conditions, about 3.5 times more. For macular degeneration, which is very common among older people, about 40.6 times more risk. You'll be have more chance of developing this disease later in life if you have high myopia over -5. And with this disease, and you see the right side, the green picture with the green background, you cannot see things clear in the center when you see in the back. So this is a pretty scary disease, and generally there is no cure. The next one is glaucoma, which is a slowly degeneration of the optic nerve. And for eyeballs that are too long, because they're nearsighted, it squeezes the blood supply going to the optic nerve and causing a slow damage to the back of your eyes. And in advanced stage of glaucoma, you see tunnel vision, like the last picture. You don't see the center, you don't see the side. It's pretty scary because you don't know you have glaucoma until your tunnel vision become become obvious. But that by then you will lose a lot of vision. So there's almost three times more risk of developing glaucoma with a high degree of myopia. and cataract is another one. Higher, you have higher degree of myopia, it's 8 times more chance of developing cataract. So how do we prevent? Now the question is that we know myopia is bad. We know that high myopia is even worse. So our chances, our purpose is to make sure we do not develop into a very high degree of myopia. And if you don't have myopia, hopefully we don't develop to have any myopia when hopefully you don't get myopia. But if you already have myopia when you're a child, we want to do things to prevent it from going to become a highly myopic. So when a child is already highly myopic, we want to make sure that it does not continue to increase, because the higher the myopia, the more chance of developing this vision-threatening eye disease. So we have ways to prevent, and we have really 5 ways to prevent the increase of myopia among children. So let's look at one at a time.
Yep. Dr. Leung, I'd like to, at this point now, kind of ask our audience too, of our 17% that was maybe more highly myopic, 80% that was, under 5, but, almost all, I'd say about 80% of you are myopic to some degree. How many of you actually have children who are nearsighted? So if you can take us maybe 30 seconds to do that. That's quite a few. So I'm going to share this with you coming in. We've got, most of you have voted. So we've got about 86% of our audience, Dr. Leung, who this talk will probably be very pertinent to, because their kids are also myopic. And we've got one more question here, which, of those kids who are myopic, we're kind of curious if you've already heard or are doing any of the kind of treatments that Dr. Leung is going to go into. So Ortho-K, atropine, if you have any kind of computer glasses, if they wear any daytime soft contacts, or if they just wear glasses, which is, we'll go over that as well. So of the people and kids who are nearsighted. I'm going to give it just a few more seconds here. All right. So Dr. Leung, these are the results that we have. It looks like
very interesting. So I'm so glad that most of us here, the children, which is this is the time that the prescription keep growing or your eye become longer and longer, are usually the fastest between the age of 8 to 14. And those are the most critical age, because the child grow tall and the eyeball become lengthening very fast. So sometimes, a child can grow an inch in a matter of a couple months. And so the eyeball proportionally increases in length a lot of the time. But from this survey, I see that many of our audience today have undergoes the most popular myopia control treatment, which is Ortho-K, and we have 45% of them are using atropine drops and using BD filler. So I'm gonna slowly go through each of the treatment method that we use. So the first thing is that, glasses has been a way to slow down myopia that was believed to be. That's an old way to do it. And occasionally you see kids wearing these funny looking glasses called executive bifocal with a line in the middle. Now, this type of glasses actually helps in certain children, that this will effectively slow down myopia progression by about 30%. But the glasses are plain too ugly. So a lot of kids would not wear them because other kids would make fun of them. And also it's only effective usually the first 1 or 2 years of wear, and only for certain type of myopia. So another type, which is there's no line, is a bifocal with no line, and it's a progressive bifocal. It has some small effect, maybe 5 to 10% effect in slowing down myopia, but if it's used properly, because there is no zone in the lens, and the kid generally just lock all over the eye, the surface of the lens. So if you don't use it properly, it's totally ineffective. So very seldom we use this to help for the children, because it doesn't do much for them. There is a new technology called MyoSmart. It's using new technology called DIMS technology. It's a specialty ophthalmic glasses, regular glasses, regular lenses. And these lenses, by wearing these lenses, you can, they have a little micro dots in the eye. You can't, in the lens, you can't really see it. So cosmetically very acceptable. There's a 50%, one study have shown, 50% of the children, they can reduce the increase of myopia by 50%. So it's so meaning you can wear regular pair of glasses, can slow down the myopia by 50%. And however, this is not available in the United States yet. You can find it in certain Asian country, and they only limit the distribution of these lenses to certain eye doctors to have the ability to fit these lenses properly. And we can show the next slide. You can see a little anatomy of these lenses. And then you can see that there's a little micro dots, and they're very sophisticated lenses. And we should have these lenses available as a trial, as part of a study for the DIMS technology in Golden Vision soon. Hopefully soon, probably in 6 months or so, we may have these glasses available. Another way, which is probably gold standard of myopia control, is probably night wear Ortho-K lenses. The type of lenses that some of our audience have, the children are already using, is the lens that you wear at night. And in the daytime, you see, because it changes the shape of the cornea, your child see perfect clear the next day. And it's very, very effective. The children like it because they don't have to wear glasses. But the beautiful part about it is that it really slowed down the myopia increase. Now, here's a chart to show a myopia progression. So for, let's say, an 8-year-old, a child have a -1 diopter of myopia. By 9-year-old, the right side of the chart is not controlled, so -1 diopter. On an average, among Chinese, among Asian, it's about 1 diopter of myopia increase per year. So by 9, you have 2 diopter, by 10, 3, 4, 5 to 6. Of course, the increase vary among individual, but on an average, about 1 diopter during this 8 to 14 years of age. But if we wear the wear an Ortho-K lens, if the Ortho-K lens can control the increase of myopia by 50%, then your growth from 1 to 150, rather than 1 to -2, by 13-year-old, the child will be a -3 instead of -6. There's a significant reduction in the progression of myopia. So the next slide is that we use a custom-made Ortho-K lenses. So as opposed to something that are commercially available, which is called CRT lenses, on a study showed they're about 50% effective in slowing down the myopia increase. Whereas a customized, because we design the lenses according to the shape of the cornea and using a special topographic measurement, so you can really put the lenses to fit much more closer to the cornea of the eye, we can achieve about 60 to 80% effective. So the effectiveness is much higher with a custom-made nightwear Ortho-K lenses. The concept of how it changes how Ortho-K lenses work to slow down myopia is the way when we change the front part of the eye, the cornea's shape, and it casts a certain image in the back of your eyes, the image actually prevents the prescription from going up. So when you wear a regular pair of glasses, they only correct the vision. You see clear, but when you wear an Ortho-K lens, you see clear, but you also can control the prescription from going up. Next. We can go to the next one. Now, another way to slow down myopia control progression in children is a new lens called MySight lens, which is commercially available. It just gets FDA approved. It says about 50% effective in slowing down myopia. So it's FDA approved. It should be very soon to be available, and probably any time. So Golden Vision, my clinic will be first to get these lenses available to certain people. It's a little bit less effective than the custom Ortho-K lenses that we have, but it's still, this is good for certain people who want to wear soft lenses instead of wearing hard lenses. And but with these, you have to wear the lenses during the day to see clear, whereas wearing the nightwear Ortho-K lenses, you don't, you just wear them overnight, the next day you see very clear. Now, one word about the customized nightwear lenses is very important, is that the customized nightwear lenses, you don't have to wear the lenses for an extended period of time. Usually maybe 3-4 hours will be good enough for the daytime to see clearly during the daytime. Of course, the higher the prescription, the longer you have to wear them, but generally you don't have to wear them more than 8 hours with the custom Ortho-K lenses. Next slide. Another method in slow down myopia is using an eye drop called, with the chief ingredient will be the atropine drop. 1% atropine has been used to control myopia for many years. And it's very popular in Asian countries, especially in Taiwan. More than 60% of the population of the children are using the atropine for myopia control. And certain studies have shown that it can be 95% effective on the first 2 years using this 1% atropine drops. But the thing, 1% atropine drops has a lot of side effect. Not permanent side effect. When you stop it, the side effect will go. But when you use the drop every day, and you will find light bothers your child a lot, and it would be very light sensitive, and you will have trouble focusing up close. So I've seldom used 1% atropine for treatment of progressive myopia, because it affects the study, and you cannot go outdoor because you have to wear sunglasses, and so we don't use the 1%. The next slide will show the ATOM2 study have shown, which is in 2012, a study have shown that at a low concentration of atropine drop, we dilute it 100 times, it can still be effective in slowing down myopia. Not as effective 1%, but it still has very good effect and hardly any side effect. In 2018, then there's another study show, and you can 0.01%, 0.025%, and 0.05%, by slightly higher prescription, higher concentration of atropine, and you get better result in slowing down myopia. So I have started, since the study, I've started using a customized program. So instead of using 0.01% on all the children, I will increase the concentration to higher concentration without any side effect. And sometimes we change concentration during the growth year, and we look at the individual need, what is their risk factor, how many parents they are having nearsighted, and how high the prescription are. So I can individualize a program for these for a myopia treatment with atropine drops. So generally speaking, the higher the concentration, the more effective it is. So another way to slow down myopia is lifestyle changes, and that Dr. Tsang has explained very good earlier, that we need to change our habit. You know, we will encourage our children to, you know, not to get too close to the screen, have more outdoor exercise, apply the 20-20-20 rule, and so that you take breaks in between. And so here's a very interesting picture. In China, they actually, you know, the kids are, you know, getting too close to the, when they read, and they actually put a bar there to prevent the kids from getting too close, to prevent the prescription from increasing so fast. Next slide. And we want to spend outdoor activities more, 2 hours a day, will reduce the risk of increasing myopia. The last slide that we show here is a picture of the BT50 glasses. I know some of our audience using it. Use these glasses to study, to work on computer, any close work. It's a very slight hyperopic prescription in there, relaxes the eye, and it's very good, and then also very good in slowing down the prescription, very easy to do, and it's also screen out the blue harmful ray from computer screen. So, and let's see. So I think we have some questions for Dr. Tsang. And Lillian, maybe you can go through some questions about the myths of Ortho-K, myths of myopia.
Yeah, I believe some of the parents, not just parents, I think most of the patients sometimes have some misunderstanding. So exactly, if people say, I always hear people saying that I have nearsighted, so I don't need to do anything about it. I can just go ahead and do laser surgery when I grow older. So is it true, Dr. Tsang? Or maybe Dr. Leung, you can.
So so laser, so your eye grows, the eye become longer and longer. So some of my patients said, you know what, you know, some kids' parents say, well, you know what, when the kid is only 8-year-old, I know they might, you know, the prescription is only a -2. Yes, I know they're going to increase, and you know what, I am, you know, I got my laser done now. Maybe your child, my child, can just wear glasses until become adult and do laser surgery. So, but what it is that myopia is not a reversible disease, meaning that even if you have done the laser surgery, your eye has become longer, you know, abnormally long. So then the chance of you having eye disease later, even after the laser surgery is done, your eyes are still long, then you can develop detached retina, glaucoma, and all these nasty disease. You have much higher chance of having those problems. So yes, you can do laser surgery, correct higher myopia, but the chances that your risk of having eye disease that, you know, rob your vision or could blind you later in life will still be it will be just as high as without the laser surgery. So I hope that answers your question.
Yes, and how about kids? Can the kids just go ahead and do the LASIK surgery once for all?
Well, the child's eye keep growing. So if the child would do laser surgery early, but then when the eyeball grow longer, they have to redo it again. So generally speaking, we only do LASIK surgery or laser refractive surgery after the eyes really stop growing, usually after 21 years old.
Got it. Yeah, so and then also some of the parents or patient was saying that since my parents or this is a genetic issue, so there's no way that we can slow down the nearsighted, the myopia. Is it true or not? Or maybe Dr. Tsang, can you answer the questions for us, please?
Yeah, I think Dr. Leung did a great job kind of explaining already that there are definitely genetic as well as environmental factors. And a lot of population studies, which is looking at different populations, I mentioned the Eskimo populations before, but also just, you know, various areas from Asia and or America versus, you know, Norway, for example, which has some of the lowest numbers of nearsightedness. It shows that all of these studies are consistent in showing that there are environmental factors and the rate of myopia. So you know how we're expecting 50% of the world to be myopic by 2050. The rate of myopia is growing faster than genetic mutations. So genetics usually grows very, very slowly, generation to generation, but the rate of myopia is increasing much faster than that. So that proves to us that that environmental component is possible, and that changing our lifestyles, changing our habits are effective in slowing down myopia. And it's not just something that we get from our genes and we cannot do anything about.
Okay. So if I don't wear any glasses or wear a lower prescription glasses, will the myopia increase, you know, will not increase as fast?
This one is a very common one that we hear a lot in the exam room, where, you know, there's a fear of starting wearing glasses. And even when I was growing up, you know, we try to delay wearing the glasses as long as possible, thinking it'll help us with our prescription. And a lot of the latest animal as well as population studies show that that is actually not. In fact, some studies have shown that wearing a lower prescription than what you actually need is potentially increasing the prescription depending on the patient, their prescription condition. So I would say this is definitely a myth. And to the point that Dr. Leung pointed out earlier, I want to reiterate is that regular glasses, you'll notice that all the glasses Dr. Leung mentioned as a way to prevent, they were like the bifocal with the line, the progressive, the special lens glasses. He did not mention a single vision or a regular type of glasses that we normally wear to see. That one does not have any effect. So regular glasses don't have any effect in controlling the prescription, and wearing a lower prescription can sometimes negatively affect and cause a higher.
Thank you. Yeah, so I also, a lot of patients has been asking some other questions.
Great.
Okay, maybe we can go through a little bit later.
Yep. I think we just have a summary slide, and then, you know, we talk about this part already. Dr. Leung did a very, very good kind of the type of treatment options that we have here. One big one is that you may need a combination of all the treatments. It's not just one thing that may work. So I'm going to let Dr. Leung, if you have any kind of last thoughts or summary thoughts that you want to.
Great. I think so we have basically 5 different ways to correct myopia. One is the least effective way until, except for the up-and-coming MyoSmart glasses, it's just regular glasses, just ophthalmic glasses, the glasses you wear on your eyes. And they're not the most effective, but nevertheless, we still use them. The gold standard is the nightwear Ortho-K lenses, and the custom design is the one that is really the most effective. And sometimes I have kids that they have as low as 1 diopter, and they're like 12 years old in 1 diopter, and now he's graduating from college, and they're wearing a -2. So there's increase because slow down so much with these custom design nightwear Ortho-K lenses. So the other one is soft multifocal lenses, and the MySight lenses, so the FDA approved lens, but then we also have custom-made, custom designed soft multifocal lenses are a little more effective than the the MiSight lenses in terms in control the myopia increase. And then we have the different concentration of eye drop, the atropine drop, and we can titrate the different concentration, and we have lifestyle changes, outdoor exposure using your B50 glasses when you use close work. So I use a whole combination of these, this method, depending on the genetic factors, depending your lifestyle, your age. So I use a combination of different method, sometimes one, sometimes two. So not all patients are like, almost shoe size is not always the same. I really believe in a customized myopia control program. So, so let's say this is, I think this is the, I think we can wrap it up by going to some of the questions that the audience has. Lillian,
Yes.
can you sort of, see if you can share the questions with us and see maybe Dr. Tsang and I can sort of clarify a few things.
Yes. First of all, I do see how young can the kids start doing the treatment for myopia?
Treatment for myopia, how young? There
How
is
young can the kids
really, the youngest we do probably for Ortho-K, about 7 years old, 7.5. That's the youngest. But we start doing treatment even younger than that with eye drops because eye drops is much easier to administer. So, and sometimes if the parents are high risk parents, both parents are high myopia, and the kid started to be myopic very young, meaning if every year increase one diopter, it'll be very high. So we may be even more aggressive in increasing the concentration of the atropine to up to even 1% in very severe case. And so yes, we can start using one of the methods to treat myopia, but if nothing is done, outdoor activities and good lifestyle, practice good lifestyle can help a lot.
All right. And I do have another audience asking about how many hours to wear Ortho-K lenses at night while sleeping.
This is a very, very common question. In my exam room, I get asked a lot. And it's because now schoolwork is very heavy. I don't know, when I went to school in high school, there's hardly anything to do. Very, very easy. Now our children spend hours and hours studying, and many of them don't find enough sleep. Using a, generally speaking, when you wear Ortho-K, using a not, sort of like a off-the-shelf type Ortho-K lens, and you probably require about 8 hours of sleep, 8 to 10 hours of sleep, in order to see clear throughout the day. But using a customized Ortho-K lenses that we call it Gold Design lenses, and not only can slow down myopia at a to 60 to 80% effective, but it also doesn't require that much sleep. So if a low prescription, they can sleep for 3 hours, and so you don't really have to worry about having the kids sleep a certain number of hours. And if they sleep a lot, wear the lenses. If they sleep very little, wear the lens the next day, the chance they see very clear when they go to school.
All right, thank you, Dr. Leung. And I also have a couple of audiences asking similar questions about the insertion of the contact and the removal of the contact, either by using hand or plunger. Is it very hard to insert or remove the contact by using the plunger? Is it going to be harmful, or the patient is asking about those technical things?
Maybe Dr. Tsang can answer this question.
Yeah, we usually teach with the plunger method initially. That way the patient is a little bit easier to ease into the insertion and removal technique and kind of get used to it. But a lot of our patients through the years, they'll learn how to take it off without it. So we can send you kind of a video if message, when we get back in person, we do any trainings, any of the follow-ups, just come on in and we'll teach you in person on how to remove them without a plunger, because sometimes as they get older, they go to science camp, they go traveling, you lost your plunger. It is possible, it is safe, but there's a few techniques on both of them. I guess I can highlight a couple techniques. If it's with the plunger, really recommend that you make sure that you put a little eye drop in and make sure the lens moves a little bit before you take it off the eye, because over the nighttime, sometimes it can get a little bit tighter. And when you're using the plunger, try not to aim it in the center, kind of aim it more towards the bottom of the lens where it's a little bit thicker, so that it's better for the lifetime of the lens. And then in terms of doing it without a plunger completely, definitely would want to do, we can send you videos, but if the patient is uncomfortable or anything like that, we are more than happy. We have lots of skilled technicians who have been doing contact lens themselves and training for a long time. So we can definitely teach you how to do that.
I'm just going to go back and answer that question. When one of our patient asked about his child, 7-year-old girl, and for 7-year-old, I think one easy way to start, besides having more outdoor activities, you can do a lot now with the lockdown. You spend a lot of time with the kid, but once it may not be very practical all the time. I mean, 2 hours a day outdoor, it would be easy for the kid, but it's hard for adult to spend that much time with them. I think one good way is to, even if the prescription, we can use eye drop as the first treatment. We can use a very low concentrate eye drop, diluted 100 times or even less, as a prophylactic treatment for even without nearsighted. We can even start the drop, because there's really no side effect, no harm to start the drop as early as 6 or 7 years old. So hopefully it's a little bit more specific to the answer. Yes, yeah, we can get started with myopia control, most likely with the drop when you're very young.
Yes, I mean, I think even just for a kind of a fun anecdotal story, I've had a 6-year-old in Ortho-K, but it's not typical, like we have to look at the maturity of the child, the risk factor for the parents, but things are definitely possible, and we kind of tailor each case to that patient. We've even had some patients, while we were in this quarantine unique situation, where they started atropine during this time period without getting fit for Ortho-K initially. So there's definitely lots of options out there.
I really can't emphasize more about a program. It's not one method fits all. And because every child, every patient, they have a very different presentation about their condition of myopia. How fast it progresses, how old is the onset of myopia, and genetic factors, both parents, how high the prescription of the parents, and how the kids are like. Is the patient, if the kid is very obedient, very calm, some kids are more, sort of more active, and some kids don't spend a lot of time outdoors, some do. So we have to weigh all these factors and see, because after all, it's the kid who wear the lenses, and how we can motivate them to wear a certain type, use a certain type of treatment. I can give them the lenses. If they don't use them, it will be a waste of money for the parents, a waste of time for the kids, a waste of time for us. So I think we generally speaking, we do have to interview the parents and the kid, and we do all the testing we need to come up with a program that is not only for the day, but we are programmed that we can change the program as the child grows, as they see the treatment, however we control. So we can change the program as the course, during the course of the child's growing. From, let's say, from 7 to 14, we can see the trend, so we can modify the treatment program as the child mature. So so I would say there is always a team. The team will include the parents, our golden team, my technician, our doctor team, and the child. So the three make a teamwork to slow down, to combat the progression of myopia. So I think this sort of sum up if Dr. Tsang, you have some take-home message you want to share to emphasize certain things, and hopefully, we can, we're about 5 minutes out to 1 hour, and then Lillian, you can, if there anything, any other answer, any questions, and you can sum it up.
Yeah, I'm pretty sure. Yeah, Dr. Tsang, you may. Yeah.
Mm-hmm.
Anything to add?
I just have one quick thing that I really thought was interesting is just reducing that rate by 50% really decreases that risk of high myopia by 90%. So you can make small changes, but make big influence on the long term. And so I want to reiterate that point. And then I see in the chat bar, there's a lot of kind of individualized questions. So I want to thank everybody for being so open to this kind of new format that we're talking to each other and connecting with you guys as much as we can. And we're going to kind of touch base with you individually to make sure that all your appointments and everything are taken care of. So I'll let Lillian take it from here. Thank you, guys.
Thank you, Dr. Leung and Dr. Tsang, for sharing all these informations with us today. So I'm sure a lot of you still have a lot of questions. So just quickly, I do see the last question. If you have any issue ordering the solutions eye drops, once again, you may order the solutions eye drops through our website at goldenvision2020.com. Okay, or you can always visit us when we reopen. And later after the discussion, all the audience should be receiving an email, and you can simply just go ahead and reply to the email to ask any questions, further questions. Also, we are available for a one-on-one Zoom meeting that is open for all the audience. So you may also request the one-on-one consultation online, or you can also schedule an appointment for the in-person consultation after the office is open. And you may just go ahead and call the office number to schedule the appointment. All right. Okay. And thanks again, everyone, for joining us today for the roundtable discussion. And we'll see you next time. Thank you very much. Okay. Thank you, doctors.
Thank you.
Bye-bye.